Thank you, Ravi. And I want to echo what Baba actually said. This is a nice small meeting, which gives us an opportunity to actually discuss things in a closed meeting space. So I was asked to talk about targeting the B-cell activating factor in myeloma. And obviously, this is relevant to all B-cell diseases, not just myeloma. And just as a backdrop here, we all know that BAFF and APRIL signaling are pretty significant in the context of myeloma. I do want to spend a little bit of time on this because going forward, I'm going to show you data with tabalumab, but there are a lot of different antibodies, or even now the BiTE antibodies, which are being developed for targeting this signaling cascade. And I think some of these things are going to be relevant as we go on. So BAFF, as you all know, is generally present as a homotrimer in circulation. It can also be found in the 60-mer form. There's a bound membrane-bound form of it, as well as a circulating BAFF. And BAFF generally signals through three receptors. You have the BAFF receptor, the BCMA, and TACI. And again, the receptor status is very important specifically to B-cell development as one goes forward. APRIL, on the other hand, is also circulating. It binds to HSPGs, and it also signals through some of these, so mainly through BCMA, somewhat through TACI, and a lot through the heparan sulfate proteoglycans. We've looked at BAFF levels several years back now, and we've seen this in patients with multiple myeloma. Patients with multiple myeloma certainly have double the levels of BAFF compared to normal donors. The range here was a little over 1,000 picograms. There's other data from other investigators who've looked at BAFF levels as well as APRIL levels, and sufficely to say that if you had higher BAFF levels, your progression-free survival was worse compared to those who had low BAFF levels, and the same was true for APRIL, suggesting that both BAFF and APRIL have prognostic importance in multiple myeloma. We've also shown preclinically that BAFF specifically acts as a survival factor for multiple myeloma, so that if you have high circulating levels of BAFF, multiple myeloma cells tend to survive a little bit more. We'd use the monoclonal antibody from Lilly. This is now called tabalumab. We'd studied this in our SCEDU mouse model several years back now. We did see some anti-tumor activity. We saw an increase in survival, and what was interesting was it was mostly a microenvironmental effect of this BAFF antibody, where we saw a decrease in the number of osteoclasts, and as you can see here, the bones in these animals did have less lytic disease compared to the untreated animals. Based on that, we went ahead and did a phase 1 study. This was a combination study of tabalumab with bortezomib in patients with previously treated myeloma. This is just data showing you tabalumab. Now, tabalumab, unlike some of the other monoclonal antibodies that you've heard about this morning, is an IgG. It's an IgG4 type of a monoclonal antibody, so there's no ADCC, because oftentimes the question I get is, why did you combine this with bortezomib as opposed to combining it with an IMiD? This does not work through ADCC. The way this tabalumab would work is binding of circulating BAFF as well as membrane-bound BAFF is how this antibody would work. It has been generated so that it has an S2P mutation so that it does not produce half antibodies, and its half-life is close to 3 weeks. We designed a dose escalation study where BAFF, the tabalumab antibody, was given at the beginning of a classic bortezomib cycle. I'm not going to focus too much on the clinical details. We did do PKs on this phase 1 study, and the reason to do PKs was this was a monoclonal antibody. Given that it does not work through ADCC, it did not really cause any toxicity. So again, it was important for us to figure out as to what dose range we needed to go up to, and when we looked at doses of either 100 or 300, we started seeing a nice plateau with this, and at least in this phase 1 study, we thought we'd go with 100, but I'll show you some data later on where in the phase 2 study we've gone even a little bit higher. This was the normal demographics of these patients. 48 patients were treated on the combination of tabalumab with bortezomib, and like the classic relapse refractory patient population, these were pretty heavily pretreated. The majority of them had seen either bortezomib or an IMiD-based treatment prior to this. Looking at toxicities, the one very striking thing about this tabalumab antibody was really very little toxicity. We did see thrombocytopenia. We did see a couple of people who had pneumonias, but this was very, again, very reminiscent of what you see with bortezomib toxicity. And I really, we couldn't quite hone in on whether tabalumab was causing any of these toxicities. We did have certain AEs, which are reported here. We had 2 patients who died. Both of them died of progressive disease, one of progressive myeloma after 5 cycles. Another patient developed pneumonia and ARDS and died, but he, along with development of the pneumonia and ARDS, also had progressive disease of his multiple myeloma. This is a summary of the best confirmed response by the IMWG criteria. We had 2 people who had a complete response, 4 very good partial responses, and 16 PRs. So PRs or better was seen in 22 of our patients, and this is just a forest plot curve of the M protein and the urine light chain response in these patients who were treated with tabalumab and bortezomib. The time to progression was 4.9 months, and the duration of response in this heavily pretreated patient population was 7.3 months. Now, this is the baseline BAFF expression of the patients who went on to tabalumab with bortezomib. And the reason I talked about the dosing here was, we had quite a few patients who had pretty high levels of BAFF at the outset. So went all the way up to 11,000 or so. And if you look at the blue dots, these are the ones who did not actually respond. So we thought when we looked at our PK data that we would go forward with the 100 milligrams dose, but then when we looked at this data, we said maybe we're not giving them enough antibody to neutralize what's circulating, and which is why we may have seen this kind of a non-response. So based on our phase 1 data in this 48 patients, we found that it was pretty well tolerated. The median time to progression here was 4.9 months, and duration of response was 7.3, with 22 of our patients with a confirmed response. We have now completed the phase 2 study. This was a 240 odd patient study, and this is a little bit different from the elotuzumab study because this was truly a double-blind study. So and the reason we could do it as a double-blind study was really the tabalumab does not have toxicities. If we had to do a lot of pre-treatment dexamethasone, etc., this would have been a harder study to do as a double-blind study. So honestly, the way we randomized patients was it was a 2:1 randomization where 2 out of every 3 patients got tabalumab. We used 2 doses here. We used tabalumab at the dose of 100 and tabalumab at the dose of 300. The reason we picked 100 and 300 was the PD data, which I showed you, where we had a lot of patients with pretty high levels of BAFF, circulating BAFF levels. And this study has now been concluded. We don't have the data as yet, but in April, we'll at least get the first look on this data, and this is going to kind of decide whether we go forward with a registration label. The other thing I will tell you about this, when we first designed the tabalumab bortezomib study, the early part was done without dexamethasone at all. But we changed that around because conventionally, or the standard of care for myeloma patients who are receiving bortezomib-based regimens always uses dexamethasone in this treatment. But I think it brings up several different points. And in this case, we've used tabalumab. Tabalumab neutralizes BAFF, as I've mentioned. It works through, basically, it can neutralize the BAFF receptor, BCMA, and TACI. But I think it's important for us to figure out how relevant is this to myeloma. And if you look at some of this data, and this is old French data now, we've looked, this is Morou's data, where they looked at TACI expression in multiple myeloma cells. And TACI high expressors were patients who had bone marrow-derived plasma cells, have high TACI expressions. These are generally considered standard risk patients. Patients with a plasmablastic kind of a phenotype have TACI low expression. If you think about multiple myeloma cells, these are fully differentiated plasma cells or plasmablasts. They express a lot of BCMA, they express a lot of TACI. BAFF receptors generally not expressed in multiple myeloma. So in earlier diseases like CLL or the earlier non-Hodgkin's lymphoma patients, you will see some BAFF receptor expression, not so with myeloma. MM cells expressing only BCMA do not bind either BAFF or APRIL. So you do need that TACI. And if you remember the first slide which I showed you about signaling, APRIL signals through TACI and BAFF, but APRIL, if you don't have a high amount of TACI, APRIL's not really going to work. So do we really need to neutralize APRIL, or is BAFF a sufficient target? I think these are still all unknowns. This is data with the Tacecap, which came from Shmuel Jacobi's lab. This is an antibody against TACI, and what he showed in his preclinical models, at least, was if you have high TACI expression, you are going to see some response. This is considered kind of standard risk myeloma. And then it begs the question of what is the correct antibody to use in this setting. I've shown you data with tabalumab. Tabalumab is shown out here. Tabalumab, like I said, works mainly on both membrane-bound as well as circulating BAFF. It can neutralize this part. It can neutralize TACI to some extent, and BAFF receptor, which is not relevant in myeloma. We don't know what atacicept would do. Amongst all of these antibodies, the only one which is actually approved for the treatment of lupus right now is belimumab, and belimumab actually targets only the soluble BAFF. So each of these antibodies which are in clinical development are a little bit different. I don't think besides tabalumab, there is no other antibody which is in clinical development, at least in the oncology space. So we'll really have to wait and see what our phase 2 data shows as to how we need to move forward with this. And with that, I'll stop, and I think we'll take questions at the end. Thank you.